Okay, so today we will discuss anterolateral compartment of leg and dorsum of the foot. Okay, so leg is the part of lower limb that extends from the knee to the ankle, and the foot lies distal to the ankle. Foot has two surfaces, dorsal or superior surface. কিছু হলো? ওকে, ওটা লাগিয়ে দেবে তো যাওয়ার সময়, ঠিক আছে? So foot lies distal to the ankle. Foot has two surfaces, dorsal or superior surface and plantar or inferior surface. আর একটা ডিসেকশনের ট্রে রেডি করে রাখো, ইনস্ট্রুমেন্ট আর ম্যাকিনটস আর গ্লাভস। Most of the structures extend from the front of the leg to the dorsum of the foot. Hence, in this chapter, the front of the leg and dorsum of the foot are described together. Okay, so see, this is a section through the leg. First, superficial most you will get the skin, after that superficial tissue, then green colored one is the deep fossa. Okay, deep to the deep fossa are the muscles and deep most is the bone, and this is section of the fibula. This large section is of tibia. Okay, and these two are connected via interosseous membrane. These are also part of deep fossa, deep transverse facial septum and superficial transverse facial septum. And these are the posterior intermuscular septum, anterior intermuscular septum. These septums divide the muscles into three compartments: anterior compartment, lateral compartment, posterior compartment. And these two deep septa are dividing the muscles of the posterior compartment. Okay. So today we will discuss anterior compartment and lateral compartment. You can see lateral compartment lies between the anterior and posterior intermuscular septum. Anterior compartment lies between the lateral surface of the tibia, interosseous membrane and anterior intermuscular septum. So this is anterior compartment, this is lateral compartment. Okay, so now we will discuss the compartments. So the deep fossa of the leg sends the septa to the tibia and fibula and divides the content of the leg into three compartments: anterior, posterior and lateral compartment. The deep fossa fuses with the periosteum at the subcutaneous parts of the tibia and fibula, and that includes the medial surface of tibia and malleoli. Anterior compartment of leg lies between the tibia, interosseous membrane, fibula and anterior intermuscular septum. See here, this is the anterior compartment lying between the tibia, fibula, anterior intermuscular septum, interosseous membrane and the deep fossa. Okay, this is the boundary. Next, lateral compartment of leg lies between anterior intermuscular septum, fibula, posterior intermuscular septum. See here, this is lateral compartment lies between the fibula, anterior and posterior intermuscular septum and superficially deep fossa. Okay, so this is lateral compartment. Next, posterior compartment of leg lies posteriorly between the tibia and interosseous membrane, fibula and posterior intermuscular septum. So this is posterior compartment lies between tibia, fibula, interosseous membrane, posterior intermuscular septum and this deep fossa. Okay, so these are forming the boundary of the posterior compartment. Understood? So three compartments are clear. Today we will discuss this anterior compartment. Okay. So these are the important surface landmarks of this anterior compartment. Medial and lateral condyles of tibia. They are felt at the sides of the ligamentum patelli. See here, at the upper end of tibia, these projecting parts are the condyles, medial and lateral condyles of tibia. felt at the sides of ligamentum patelli, especially in flexed knee position with laterally rotated flexed thigh. Okay. Tibial tuberosity, this prominent projection is tibial tuberosity. It is a bony prominence that is felt anteriorly 2.5 cm distal to the knee joint and provides attachment to the ligamentum patelli. Okay, that's why it is important, tibial tuberosity. Next is anterior border of tibia or seam border. See, this is anterior border, also known as seam border. It is subcutaneous except in the lower part of the leg. It is sharp and sinuously curved bony border. Extends from tibial tuberosity to the anterior border of the medial malleolus. Next is medial surface of the tibia. This part is medial surface of tibia. It is subcutaneous except in its upper part where it receives the insertion to the sartorius, gracilis and semitendinosus. These three are coming from three parts of the hip bone and forming the gyro. Lower one third of this surface is crossed obliquely by the great saphenous vein here in this lower part. Next is medial malleolus. It is a bony prominence on the medial side of ankle. Here this bony prominence is medial malleolus. Head of fibula lies posterior lateral at the level of tibial tuberosity. This is head of fibula. Okay. Neck of fibula lies just distal to the head of fibula. So just below the head, this part is neck. Lateral malleolus is bony prominence on the lateral side of the ankle, extends about 0.5 cm below the medial malleolus here. This is lateral malleolus. Okay. This bony prominences are important for giving incisions. Okay. For anterolateral compartment, we are extending the incision from this tibial tuberosity to the head of the fibula. Horizontal incision and second horizontal incision from medial to lateral malleolus. Then we will extend a vertical incision from midpoint of first horizontal incision to midpoint of second horizontal incision. Then we will reflect the skin flaps medially and laterally. Okay, that's why you have to know this bony prominences. Next is peroneal trochlea and also surface marking comes from these points. All these are important. Head of fibula, medial malleolus, lateral malleolus, these are important. Tibial tuberosity, all these are important for your surface marking. Next is peroneal trochlea. It can be felt as a small bony prominence and about a finger's breadth below the lateral malleolus. Okay. Here in this region lie the peroneal trochlea. Sustentaculum talli, it is a bony prominence that can be felt about one thumb's breadth below the medial malleolus. Here will be the sustentaculum talli. Then there is tuberosity of the navicular bone. It can be felt about 3 to 4 cm antero-inferior to the medial malleolus. Okay. So, just below this sustentaculum talli, below and in front, at this region you will feel the tuberosity of the navicular. Next is tuberosity of the base of fifth metatarsal bone. It is the most prominent bony landmark along the lateral border of the foot, lies midway between the heel and the root of little toe. Okay, this is tuberosity of base of the fifth metatarsal, lies midway between heel and base of the little toe. Okay, so these are the important bony landmarks. Next is soft tissue landmarks. Prominence of the calf. Okay, this is present posteriorly. Posterior prominence formed by gastrocnemius and underlying soleus muscle form a prominence of the calf. Okay, posterior aspect of the leg you will see. Then tendocalcaneus or calcaneal tendon. It is a strong, thick tendon of gastrocnemius soleus and plantaris muscle, and that form the prominence behind the ankle. Okay. Pulses, these are some clinical aspects. Arterial pulsations are felt in relation to the tendons. Okay, so pulsation of anterior tibial artery can be felt about 2 centimeter below and behind the medial malleolus. Okay, so first you have to locate the medial malleolus, then you have to go 2 centimeter below and behind to feel this anterior tibial artery. These are felt during during feeling the pulsations of peripheral arteries. Okay, pulsations of dorsalis pedis. This is very frequently given clinical aspects. Okay, uh, where it is felt can be felt on the dorsum of the foot about 5 centimeter distal to the malleoli, lateral to the tendon of extensor hallucis longus. Okay, in final year also you have to palpate these arteries. Next is tendon of tibialis anterior. It becomes prominent on inversion of the foot, crosses the anteromedial part of the ankle. Okay, this tendon you will see tibialis anterior. Okay. Next we go to the superficial fossa of the leg. The superficial fossa of the leg and dorsum of the foot contains cutaneous nerves and superficial veins. Superficial veins, see this is the these are the superficial veins. You can see here these are the dorsal digital veins lying on each side of the fingers. They join, adjacent veins join to form the dorsal metatarsal vein. Dorsal metatarsal veins are draining into this dorsal venous arch. Okay, and this dorsal venous arch is also joining with the medial marginal vein medially, lateral marginal vein laterally, and medially it is continuous upward as the great saphenous vein, which is lying anterior to the medial malleolus, and laterally it is continuous as the small saphenous vein, which is lying posterior to the lateral malleolus. These relations are important. Okay. So superficial veins of the front of the leg and dorsum of the foot are as follows: dorsal digital veins, medial marginal vein, lateral marginal vein, 4 dorsal metatarsal veins, dorsal venous arch, great saphenous vein and small saphenous vein. Okay, so superficial fossa contain these superficial veins and cutaneous nerve. Cutaneous nerves we will also discuss. So these veins are important here. You have to see these veins during dissection. Next is dorsal digital vein. For each toe, there are 2 dorsal digital veins. See here, on each side of the toe, there are 2 dorsal digital vein for each toe. And dorsal digital veins of adjacent toe join to form 4 dorsal metatarsal veins. These are the 4 dorsal metatarsal veins. Dorsal digital veins on the medial side of the great toe continues as medial marginal vein. Here is the medial marginal vein. Dorsal digital vein on lateral side of little toe continues as lateral marginal vein. Here is lateral marginal vein. Dorsal venous arch, this is dorsal venous arch, lies on the dorsum of the foot over the proximal parts of the metatarsal bones and receives 4 dorsal metatarsal veins. Okay, understood? এইগুলো, these small veins, these are the dorsal digital veins. They are joining to form the dorsal metatarsal veins. Okay, understood? Next we go to great or long saphenous vein and small or short saphenous vein. Great saphenous vein, it is formed by union of medial end of dorsal venous arch here and the medial marginal vein. These two join to form the great saphenous vein. Course, the dorsal great saphenous vein continues upward in front of medial malleolus, crosses lower third of the medial surface of tibia, and then it follows medial border of tibia to reach the back of the knee. Next we go to small or short saphenous vein. It is formed by, this is the course of great saphenous vein in the leg. Okay, in the thigh also you have seen the great saphenous vein. It is going to drain into the femoral vein after passing through the saphenous opening. So next we go to small or short saphenous vein. It is formed by union of lateral end of dorsal venous arch, this is lateral end of dorsal venous arch, and the lateral marginal vein. And the lateral marginal vein. These two join to form the small saphenous vein. The short saphenous vein runs upward behind the medial malleus, lateral malleolus. This will be lateral, okay, lateral malleolus, and then on the back of the leg. Short saphenous vein is accompanied by sural nerve. Okay, this is also important, this relation. So there is some clinical aspect regarding the saphenous veins. So saphenous cut down. In this procedure, the great saphenous vein is easily accessed through a small skin incision anterior to the medial malleolus, and it is useful for intravenous infusion, especially in infants, obese people, and people with collapsed vein in hypovolemic shock. Okay, in severe dehydration, also a saphenous cut down you have to do. Okay, and in infants and obese people also it is difficult to find a superficial vein. That's why saphenous cut down is done. Next is saphenous vein grafts. You have seen in coronary artery bypass graft, saphenous vein is used. Great saphenous vein is used for the coronary artery bypass graft. So great saphenous vein is useful for coronary artery bypass grafting because of its easy accessibility, larger size and length with sufficient quantity of smooth muscle and elastic fibers in its wall. Why this is also explained why question. Why great saphenous vein is used for coronary artery bypass graft. Okay, so you have to write down all these reasons. Next is saphenous nerve injury. Saphenous nerve may get injured in saphenous cut down, and these patients may complain pain or numbness along the medial border of the foot. Medial border of the foot is supplied by this saphenous nerve. We'll see in next pictures. See here, this is saphenous nerve. Medial border of the foot up to the ball of the great toe, it is supplied by the saphenous nerve. Okay, and along in this part, it lies along the course of the great saphenous vein. That's why high chance of injury to saphenous nerve during saphenous cut down. Next, we will discuss the cutaneous nerve. These also you will get in the subcutaneous plane. These are fine nerves. This you may see or may not see. So cutaneous nerves of the skin and the dorsum of the foot are as follows. Infrapatellar branch of saphenous nerve. Here is the infrapatellar branch of saphenous nerve, trunk of the saphenous nerve, lateral cutaneous nerve of calf here, and superficial peroneal nerve. This is superficial peroneal nerve. It is again divided into medial and lateral branches to give supply to the dorsal digital nerves. Okay, digital branches of medial and lateral plantar nerves. These are supplying this part near the tip of the toes, coming from the sole of the foot. And this part, lateral part, is supplied by the sural nerve. So this is the cutaneous supply of leg and dorsum of the foot. Understood? So infrapatellar branch of saphenous nerve here, root value is L3, L4, pierces the sartorius muscle and fascia lata on the medial side of knee. It curves downward, forward and supplies the skin over ligamentum patelli. Along with the branches of femoral nerve and saphenous nerve, it forms plexus patelli, patellar plexus. Okay. Next is saphenous nerve. This is saphenous nerve. Root value is L3, L4. Branch of posterior division of femoral nerve. Leaves the adductor canal by piercing the deep fossa. You have seen saphenous nerve in the adductor canal. Okay. So it leaves the adductor canal by piercing the deep fossa between sartorius and gracilis, and it descends downward in front of the saphenous vein. Okay. What is the distribution? It gives branch to the subsartorial plexus, also gives infrapatellar branch. Here is the infrapatellar branch we have discussed already, and it supplies the skin of the middle side of the leg. Here, skin of middle side of the leg and medial border of the foot up to the ball of the great toe. Okay, so medial border of the foot up to the ball of the great toe. This gives you cutaneous supply. Next we go to lateral cutaneous branch of calf. Here is the lateral cutaneous nerve of calf. Root value is L5, S1, S2. It is a branch of common peroneal nerve, pierces the deep fossa over the lateral head of gastrocnemius, descends downward. It supplies the skin of upper two-thirds of the leg laterally. Okay, upper two-thirds of the leg laterally. Next is superficial peroneal nerve. This is superficial peroneal nerve. Root value is L4, L5, S1. It is a branch of common peroneal nerve, arises at the neck of fibula, at the junction of near the neck of the fibula. Common peroneal nerve is dividing into superficial and deep peroneal nerve. Superficial peroneal nerve is giving cutaneous supply and it is nerve of the lateral compartment of the leg. And deep peroneal nerve, it is the nerve of the anterior compartment of the leg. Okay, and for the posterior compartment, nerve is the tibial nerve. All the muscles are getting supply from tibial nerve in the posterior compartment. So in the thigh also you have seen different nerves for different compartments. For hamstring compartment, sciatic nerve. For the medial or adductor compartment, obturator nerve. For anterior compartment or extensor compartment, femoral nerve. Okay, you have seen these three nerves. So what is the distribution? Skin over the lower one-third of the lateral side of the leg. Here, lower one-third of lateral side of leg. Skin of dorsum of the foot. Almost most of the part of the dorsum of the foot except these areas. Okay, except the lateral border of foot that is supplied by sural nerve. Here is supply of sural nerve. Medial border up to the ball of great toe that is supplied by saphenous nerve. Here saphenous nerve is supplying, and cleft between the first and second toe that is supplied by deep peroneal nerve. Here cleft between first and second toe supplied by deep peroneal nerve. This cutaneous supply of leg and dorsum of the foot comes as a short note. Okay, so this is important. Cutaneous supply. Digital branches of medial and lateral plantar nerve, they curve upward to supply the distal part of dorsal aspect of toes and nail beds. This distal part is supplied by nerve coming from sole of the foot. These are digital branches of medial and lateral plantar nerve. Okay, understood? This is the cutaneous supply of and anterolateral aspect of leg and dorsum of the foot. Next we go to the deep fossa. So in the superficial fossa you have got the cutaneous nerve and the venous arches and different superficial veins. After that you will see the deep fossa of the leg. Deep fossa of the leg is strong and holds the content of the leg in position. Okay, so the green colored one is the deep fossa. It sends the following intermuscular septum: anterior and posterior intermuscular septum. Here you can see anterior and posterior intermuscular septum attached to the fibula. These septa divide the leg into anterior, lateral and posterior compartments. You have seen these three compartments. Deep fossa sends another two septum: superficial transverse intermuscular septum. Here is the superficial transverse intermuscular septum, and here is deep transverse intermuscular septum. These transverse septa divide the posterior compartment of the leg into superficial, intermediate and deep compartments. Okay, this is superficial, intermediate and deep compartment of the posterior compartment of leg. So deep fossa fuses with the periosteum at the medial surface of tibia and subcutaneous surfaces of the malleoli. What is retinacula? Retinacula, there are 5 retinacula around the ankle. Okay, so retinacula, deep fossa condenses around. You have seen flexor retinacula over the wrist. So like this, near the ankle also we have retinacula. Okay, flexor, extension and peroneal retinacula are there. So retinacula deep fascia condenses around the ankle joint to form strong fibrous bands called the retinacula, and there are 5 retinacula around the ankle joint. Superior and inferior extensor retinacula, superior and inferior peroneal retinacula, and flexor retinacula. And these retinacula hold the long tendons in position and prevents their bowstringing during the movement of the foot. Okay, so that they cannot displace during flexion of the foot and the ankle. So we will discuss the retinacula and their attachments. First is extensor retinacula. See, this is superior and this is inferior extensor retinacula. Okay, so extensor retinacula consists of superior and inferior extensor retinacula. The superior extensor retinacula is a broad band of deep fossa situated in front of the ankle. This is superior. Width is about 3 cm. Attachment medially it is attached to the lower part of anterior border of tibia. Here is the lower part of anterior border of the tibia, and laterally attached over the lower part of anterior border of the fibula here. And medially it splits to enclose the tendon of tibialis anterior. Here it splits to enclose tendon of tibialis anterior. Next we go to inferior extensor retinaculum. This Y-shaped structure is the inferior extensor retinaculum. It is a Y-shaped band of deep fossa situated in front of the ankle and proximal part of dorsum of the foot. It has a stem and upper and lower band. So this part is stem, here is the upper band, here is lower band. What is the attachment? Stem is attached to the anterior non-articular part of superior surface of calcaneum in front of sulcus calcaneae. Here it is, stem is attached. And the upper or proximal band is attached to the anterior border of medial malleolus. Here, anterior border of medial malleolus, upper band is attached. And lower or distal band blends with the plantar aponeurosis. Here the distal band is blends with plantar aponeurosis. The upper band passes upward and medially, whereas the lower band passes downward and medially. Okay, upper band passes upward medially, lower band passes downward and medially. Now the structures passing under the extensor retinaculum. Okay, this is important. These structures we have to see in the dissection. Okay, so the following structures pass deep to the extensor retinacula from medial to lateral. Okay, these structures are also asked lying structures lying over the tibia, over the lower end of tibia on the anterior surface. Okay, so all the same structures are lying. From medial to lateral, tibialis anterior, extensor hallucis longus, anterior tibial artery with veni comitatus, deep peroneal nerve, extensor digitorum longus, and peroneus tertius. You can remember like this mnemonic. The Himalayas are not dry places. T is tibialis anterior, extensor hallucis longus, hallucis, and A is artery, anterior tibial artery with veni comitatus. N is nerve, deep peroneal nerve. D is extensor digitorum longus, this is one muscle, and peroneus tertius, P. Okay. Another Bengali mnemonic is there. TB hole ami bhai, noroker dak pai. Okay. TB is tibialis anterior, hole is extensor hallucis longus, ami bhai is artery with veni comitatus, noroker duct pai, N is nerve, D is extensor digitorum longus, and P is peroneus tertius. Okay, so as you wish you can remember like this. Now some interesting facts are: get saphenous vein crosses the medial surface of medial malleolus. You have to expose the extensor retinacula to identify the structures passing deep to this, and all these structures you will get after reflecting the extensor retinacula. Okay. See these structures: superior extensor retinacula, inferior extensor retinacula, Y-shaped. Structures lying deep to it from medial to lateral, you see. This is tibialis anterior. Then extensor hallucis longus. Then this is anterior tibial artery. And also on the two sides of the artery there are many complexities. Then deep peroneal nerve. Then extensor digitorum longus. And here is peroneus tertius. Sometimes peroneus tertius is considered as fifth tendon of this extensor digitorum longus. Okay, understood? So these are the structures we will get under cover of the extensor retinaculum. You practice a schematic diagram like this: tibialis anterior. This is extensor hallucis longus, anterior tibial artery, deep peroneal nerve, extensor digitorum longus, peroneus tertius. Okay, superior and inferior extensor retinaculum. So extensor retinacula, superior and inferior. Superior attachment, medial attachment, anterior border of tibia, lateral attachment, anterior border of fibula. Inferior extensor retinacula Y-shaped, these are the attachments. Stem is attached to her calcaneum, upper band medial malleolus, lower band bleeds with plantar aponeurosis. Structures passing deep to it is the tibialis anterior, extensor hallucis longus, anterior tibial artery, deep peroneal nerve, extensor digitorum longus, peroneus tertius. Okay. Now this is the boundary of the next we go to, so we have discussed deep fossa and the structures lying deep to the retinaculum. Next we go to the anterior compartment. We will see the boundary and the muscles there. Nerves and vessels also we will discuss. So anterior or extensor compartment of leg, it is bounded by anteriorly by deep fossa of the leg, posteriorly by interosseous membrane, medially by lateral surface of shaft of tibia, laterally by anterior intermuscular septum. What these are the contents of anterior compartment? These muscles, or those tendon we have seen deep to the retinacula, these muscles are included in the anterior compartment. So tibialis anterior, extensor hallucis longus, extensor digitorum longus and peroneus tertius. Artery is anterior tibial artery, nerve is deep peroneal nerve. Okay, so anterior compartment of leg contains these four muscles: tibialis anterior, extensor hallucis longus, extensor digitorum longus, peroneus tertius. Common features of muscles of anterior compartment are action. All these muscles are dorsiflexor of the ankle joint. They can pull the body forward when the foot is fixed on the ground during walking. What is the nerve supply? All these muscles are supplied by deep peroneal nerve. And origin, all these muscles originate from fibula except the tibialis anterior that originates from the tibia. Okay. See here, this is tibialis anterior. Origin is from distal part of lateral condyle of tibia, upper 2/3 of lateral surface of tibia, adjoining anterior surface of interosseous membrane. This shaded area is interosseous membrane. And insertion into the medial cuneiform and base of first metatarsal. Okay. And second muscle is extensor hallucis longus. Origin is from middle 2/4 of the medial surface of shaft of tibia, here interosseous membrane, and insertion into the extensor hallucis longus. Hallucis means going towards the great toe and longus means it will be inserted into base of distal phalanx. Okay. So base of distal phalanx of great toe, extensor hallucis longus. Next, third muscle is peroneus tertius. Origin is from lower 1/4 of medial surface of fibula and interosseous membrane, and insertion is into medial part of base of fifth metatarsal. Okay, this will be tarsal. So we will discuss individual muscles. Tibialis anterior, you can see here, this is tibialis anterior. It has a spindle shaped belly with multipennate fibers. Originates from lateral condyle of tibia, upper 2/3 of lateral surface of shaft of tibia. All this can be given in your OSPE. Okay, you have to identify a structure and then you have to answer regarding questions, okay, related to the structure. So, tibialis anterior originates from lateral condyle of tibia, upper 2/3 of lateral surface of shaft of tibia, anterior surface of interosseous membrane and covering deep fossa. Direction of fibers, the fibers descend vertically downward to form a broad tendon and that passes deep to extensor retinaculum. What is the insertion? This is the insertion. Inserts on medial and inferior surface of medial cuneiform and base of first metatarsal. This is the insertion. Okay. Innervation by deep peroneal nerve, anterior compartment muscle. Action performs this following action: dorsiflexion of foot at ankle joint. This is chief action. Inversion of foot pulls the foot inward. Okay, and maintains the medial longitudinal arch of the foot. These are the functions of tibialis anterior. How will you test? Ask the patient to walk on their heel to test the dorsiflexion of the ankle, which is the chief action of tibialis anterior. Okay. Next muscle we will go. So tibialis anterior origin, lateral condyle of tibia, upper 2/3 of lateral surface of tibia, interosseous membrane. Insertion, medial cuneiform, base of first metatarsal. Innervation, deep peroneal nerve. Action, dorsiflexion, inversion of foot and maintenance of arch, medial longitudinal arch. Next, extensor hallucis longus. So this is extensor hallucis longus. Okay, this is the origin, middle to fourth of medial surface of shaft of tibia, interosseous membrane. Most of the upper part of extensor hallucis longus is covered by tibialis anterior and extensor digitorum longus. Extensor hallucis longus originates from posterior part of middle to fourth of the medial surface of shaft of fibula and anterior surface of interosseous membrane. This is direction of fiber. Fibers run vertically downward to form a tendon and that passes deep to the extensor retinaculum. This is the insertion. Extensor hallucis longus inserts on the dorsal surface of base of distal phalanx of grade 2 here. Dorsal surface of base of distal phalanx of grade 2. Okay. Innervation, deep peroneal nerve. Action, it performs dorsiflexion of foot at the ankle joint and extension at the metatarsophalangeal and interphalangeal joint of grade 2. This is the clinical testing. Ask the extend the grade 2 against resistance and observe or feel the prominent tendon of extensor hallucis longus lateral to the tendon of tibialis anterior. Okay. Next we go to peroneus tertius. A summarization of extensor hallucis longus, origin from middle to fourth of medial surface of fibula, interosseous membrane. Insertion, base of distal phalanx of grade 2. Insertion, deep peroneal nerve. Action, dorsiflexion of foot, extension at metatarsophalangeal, interphalangeal joint of grade 2. Next, extensor digitorum longus. See, this large muscle is extensor digitorum longus. It is dividing into 4 tendons for the lateral 4 toes. Okay. So origin is from here. Extensor digitorum longus originates from lateral condyle of tibia here. Whole of the upper 1/4 and medial part of middle 2/4 of anterior surface of fibula. Here anterior surface of fibula, anterior surface of interosseous membrane. Direction of fibers, the fibers run downward and medially to form a tendon that passes deep to extensor retinacula. Tendon divides into 4 slips on the dorsum of the foot here and each slip runs to the corresponding 4 lateral toes. Okay, here it is going to be inserted. Insertion, it inserts on the middle and distal phalanx of the 4 lateral toes, 2nd to 5th toes. A metatarsophalangeal joint, at the metatarsophalangeal joints, each of the tendon to 2nd, 3rd and 4th toes are joined on the lateral side by a tendon of extensor digitorum brevis. Okay, this is one intrinsic muscle of the dorsum of the foot to form the dorsal digital expansion. Okay, in the upper limb also you have seen dorsal digital expansion. The lumbricals and interossei was going to be inserted into the dorsal digital expansion. Here this muscle is forming the dorsal digital expansion along with the tendons of extensor digitorum brevis. Okay. So what is the action? Innervation is deep peroneal now, as it is a muscle of anterior compartment. Action: extensor digitorum longus performs the following action: dorsiflexion of the foot and extension of metatarsophalangeal, proximal and distal interphalangeal joints of second to fifth toes. How will you test? Ask to extend 4 lateral toes against resistance and observe prominent tendons of extensor digitorum longus. Okay. So this is okay. So extensor digitorum longus origin is from lateral condyle of tibia, upper 3/4 of medial surface of fibula and interosseous membrane. Insertion into the middle and distal phalanx of lateral 4 toes. Nerve is deep peroneal nerve. Action: dorsiflexion of foot. Extension at metatarsophalangeal, interphalangeal joints of second to fifth toes. Next is peroneus tertius, origins from, this is peroneus tertius. Okay, originates from lower 1/4 of medial surface of shaft of fibula. Here, lower 1/4 of medial surface of shaft of fibula, interosseous membrane, anterior surface of interosseous membrane. Direction of fibers: fibers runs downward to form a tendon that passes deep to extensor retinaculum and lateral to the tendon of extensor digitorum longus. Insertion: insert on the medial part of dorsal surface of base of fifth metatarsal. Here, dorsal surface of base of fifth metatarsal. Innervation is deep peroneal nerve and action along with extensor digitorum longus, dorsiflexion of the foot along with peroneus longus and brevis, eversion of the foot. Okay. So this is peroneus tertius. Origin: lower 1/4 of medial surface of fibula and interosseous membrane. Insertion into the base of fifth metatarsal. Innervation into deep peroneal nerve. Action is dorsiflexion and eversion of the foot. Okay. Next is Fraser's syndrome or Sean splints. This is one clinical aspect. It is anterior tibial compartment syndrome that occurs due to overextension of muscles of anterior compartment. How it occurs? Pathology: sudden overuse of extensor muscles of leg causes edema in the anterior compartment of leg, and it compresses the anterior tibial artery, causing reduced blood supply to the muscle. There will be ischemia and pain in the anterior compartment. As it occurs more commonly in freshly admitted medical students and freshly recruited army personnel, it is called Fraser's syndrome. Okay. So sudden overuse of extensor muscles of leg, edema in the anterior compartment, compression of anterior tibial artery, reduced blood supply to the muscle, ischemia, pain. Okay, anterior compartment syndrome or Fraser's syndrome. Next we go to the artery. So we have discussed all the 4 muscles. Okay. Next we go to the artery and nerve. That's how you will complete. So artery. So this artery of this anterior compartment is anterior tibial artery. Anterior tibial artery in the main artery of anterior compartment of leg. It corresponds to posterior interosseous artery of the forearm. Silence everyone. What are you talking about? It corresponds to posterior interosseous artery of the forearm. Reinforcement: anterior tibial artery is reinforced by perforating branches of peroneal artery. It begins at the lower border of popliteus muscle as terminal branch of popliteal artery. Popliteal artery divides into anterior and posterior tibial artery. Okay, at the lower border of popliteus muscle. What is the course? Begins in the posterior side of leg, enters the anterior compartment of leg by passing forward through the opening in the interosseous membrane. In the anterior compartment, it runs vertically downward towards the ankle. How it terminates? It continues as dorsalis pedis artery at a point midway between medial and lateral malleoli. Okay, so it is continuing as dorsalis pedis over the dorsum of the foot. Okay, now the relations in the upper one third of the leg. Artery lies between tibialis anterior and extensor digitorum longus. Here is the artery lies between tibialis anterior and extensor digitorum longus. In the middle one third of the leg here, the artery lies between tibialis anterior, extensor hallucis longus. Tibialis anterior, extensor hallucis longus. And relations in the lower one third of the leg here, the artery lies between extensor hallucis longus, extensor digitorum longus. Okay, this is extensor hallucis longus and extensor digitorum longus. Anterior tibial artery is crossed anteriorly by the tendon of extensor hallucis longus from lateral to medial. Here you can see extensor hallucis longus tendon is crossing the artery from lateral to medial. And the deep peroneal nerve lies lateral to the anterior tibial artery in the upper and lower third of leg, whereas the nerve lies anterior to the artery in the middle third of leg. Here, in the upper one third and lower one third, nerve is lying lateral to the artery, but in the third it is lying anterior to the artery. That's why the nerve is called nervus hesitans. Okay, this deep peroneal nerve is called nervus hesitans because here it looks like it is hesitating to cross the artery. Okay, it is coming to the medial and then again going to the lateral. These are the branches, anterior and posterior tibial recurrent arteries. Okay, here one anterior tibial recurrent artery has been shown. Muscular branches supplying the muscles of anterior compartment, anterior medial malleolar artery here, and anterior lateral malleolar artery here. And after, in between the two malleoli, this is medial malleoli, here is lateral malleoli. So from this point it is continuing downward as the dorsalis pedis artery, and these are branches of dorsalis pedis. Medial tarsal, lateral tarsal, arcuate artery, first dorsal metatarsal artery, all are branches of dorsalis pedis.